Hi, I'm Whitney Hansen, and today I'm going to talk to you about hyperbilirubinemia in the newborn. This presentation is for the new hires that have been recently hired to work in our NICU at St. Joe's. Some of the nurses have NICU experience, but most of the nurses do not have any NICU experience. The objectives for this presentation are that at the conclusion of this presentation, students will be able to identify the causes of hyperbilirubinemia in a newborn, list the signs and symptoms of hyperbilirubinemia in a newborn, identify appropriate measures for treating hyperbilirubinemia in a newborn, and identify the importance of treating hyperbilirubinemia in a newborn. What is hyperbilirubinemia? Hyperbilirubinemia is also referred to as jaundice. Jaundice is the yellowing color of the skin and the white parts of the eyes. The yellowing color is caused by an increased bilirubin in the blood, which is caused from the breakdown of hemoglobin. This typically occurs because the baby's liver isn't mature enough to keep up and rid the bilirubin fast enough. Bilirubin is excreted through bowel movements. Who is at risk for jaundice? Well, infant jaundice is particularly common in breastfed babies and babies born before 38 weeks. Approximately 60% of full-term babies and 80% of preterm newborns develop jaundice. Preemies that are born before 38 weeks gestation may not be able to process the bilirubin as quickly as full-term babies do. Significant bruising during birth can cause the breakdown of more red blood cells. The blood type can also have an impact. If the mother's blood type is different from her baby's, antibodies can cause abnormal rapid breakdown of red blood cells. Breastfeeding babies who may have a difficult time nursing or getting enough nutrition from breastfeeding, and babies of East Asian ancestry. There are, however, some other causes that may cause jaundice in the newborn: internal bleeding, sepsis, other viral or bacterial infections, a liver malfunction, biliary atresia, an enzyme deficiency, an abnormality of red blood cells, thyroid dysfunction, or cystic fibrosis. Neonatal jaundice can be subdivided into two groups: unconjugated hyperbilirubinemia and conjugated hyperbilirubinemia. Jaundice is considered pathological if it presents on the first day of life. Unconjugated hyperbilirubinemia could be physiological or pathological. It's also the most common. It accounts for 75% of neonatal jaundice. It typically appears after 24 hours of age due to increased bilirubin production, decreased bilirubin clearance, breast milk jaundice, prematurity, or ABO-RH incompatibility. Conjugated hyperbilirubinemia is always pathological, and it typically signifies an underlying medical or surgical cause. It requires prompt evaluation and treatment is critical. This is often due to an impaired hepatobiliary function. This could be obstruction of biliary flow, infection, or genetic causes. Some signs and symptoms of hyperbilirubinemia include yellowing of the skin and the whites of the eyes, poor feeding, lethargy, distended abdomen, decreased stool or urine output, temperature instability, or fever. It's confirmed by a blood test to measure the bilirubin level. Not all of these symptoms are needed for hyperbilirubinemia to be present. How is hyperbilirubinemia confirmed? Well, there's really two ways. There's the TCB and blood draws. You may also hear the TCB referred to as the TC-Billy, and this is a non-invasive way to measure the bilirubin in a baby. This order is pretty standard for our NICU admissions, so be sure to double check that and make sure that you have an order for this from the provider. This is typically done after 24 hours of life, and the order may say to continue repeat testing every 24 hours until the provider discontinues this order. So you're going to take a transcutaneous bilirubinometer, and it's used to estimate the serum bilirubin. So what you're going to do is scan the baby's forehead or chest, and then you're going to document your result, and you're going to notify the practitioner of the result. If the number seems elevated, the provider will most likely want you to follow up with a serum bilirubin. So to check blood levels, the doctor or provider may write for a total bilirubin or an indirect bilirubin level, and they also may want you to have a complete blood count. They may ask for a blood type and Rh incompatibility test, which is also known as the Coombs test, and they may also want to do a blood culture to rule out sepsis. So in our NICU, we use the bilirubin Billy tool, and this is based on the 2022 AAP hyperbilirubinemia guidelines, and this tool provides the recommended treatment. It's also very helpful in that it provides information regarding when to check levels again for rebound after stopping the phototherapy. This is a sample of our Billy tool, and this is something that as a nurse you probably will not have to use. The practitioners are the ones that usually enter in all the data and calculate the bilirubin range and treatment. So here you can see, though, you would enter in the birth date, birth time, sample date, sample time. It's important that you put in the hours that they are in age at the time of drawing the blood, and the bilirubin level, and how many weeks they are. And then this tool will give you some guidelines as to whether or not phototherapy should be initiated, or whether or not any other measures need to be taken. So in our NICU, to treat hyperbilirubinemia, the most common treatment is phototherapy. And there's two ways we can do that in our NICU. We have the overhead blue spectrum lights, and this can be used in the isolette or with a warmer. Typically, if they're in a bassinet, we are going to use the fiber optic blanket, and in our NICU, we use the BiliSoft 2.0. So how does phototherapy work? Well, it transforms bilirubin into isomers that can be eliminated, which basically means it breaks down stuff without needing the use of the liver, and then the baby can pee and poop it out. So the light needs to be in direct contact with the baby's skin. So you're not going to want to have any onesies or sleepers on, and you want to try and make sure that the diaper is not covering the baby's entire back or front side. You can use single, double, or triple phototherapy depending on the bilirubin level, and you do this by adding additional lights or taking away lights. Like I said, we use the overhead lights or the fiber optic blanket. The length of treatment typically lasts 2 to 3 days, But we like to tell parents that it's not uncommon for a baby to be on phototherapy, come off of phototherapy, and then maybe have to go back on the phototherapy for a couple days. So it's always nice to kind of give them a heads up that this may unfortunately happen. So once a shift, you are going to have this in your orders to check irradiance on the phototherapy. This is to make sure that the baby is getting an adequate amount of light reaching them to break down the bilirubin. So we're going to watch this video that shows us how to check irradiance on the BiliSoft 2.0. Okay, so like I said, this is something that will be in your orders. Typically, it is to be done every 12 hours. There is a place within Epic where you're going to document the level and document that you have checked the phototherapy level. So now it's time to play. We are going to get out the Neo Blue overhead blue spectrum light. We are going to get out the BiliSoft blankets. We have the TCB reader. We have a few baby dolls with goggles. And we also have the irradiance meter checker. So we're going to take some time to really kind of play with these things, figure out how they work. We're going to put our safety goggles on the babies because it's very important that we are protecting their eyes. And all of this is also going to be documented with your cares in portfolio. You're going to want to document the type of phototherapy that's in place, that eye shields are in place, and your irradiance level if you have checked it. Okay, so let's take 10 and let's figure out how we use these devices in our NICU. Okay, you guys did a great job in learning how to use the different phototherapy tools in our NICU. And don't forget, if you find that you have questions or run into problems, we are always here to help guide you and answer your questions. Even if your preceptor is not nearby, feel free to ask any one of us and we can help you as you are learning. One of the treatments for hyperbilirubinemia that is used in more severe cases, so we're talking worst case scenario, this is an exchange transfusion. Don't panic, this is not something that you would be doing alone. This would be something you would have other nurses helping you with. The provider or practitioner would also most likely be at the bedside to assist with this. But what an exchange transfusion is you're replacing the elevated bilirubin blood in the baby with donor blood that contains normal bilirubin levels. So this is a way to kind of very quickly get that bilirubin level down. So in addition to phototherapy, there are some other supportive measures for kind of avoiding hyperbilirubinemia or lessening the severity of the jaundice. So one of the big things we want to do is increase the total fluids, and this is going to prevent dehydration and promote excretion of bilirubin. So we're going to increase IV fluids. If the baby is breastfeeding, we may want to try supplementing with formula, or we also may want to try increasing the frequency of the breast milk feedings or the volume of the breast milk feedings. Basically, we're trying to get this baby to poop out the bilirubin. We are going to be monitoring for jaundice pretty frequently, and your provider will write orders as to when they want you to check a TC bili or draw a serum bili level. And these are often repeated. Like I said, it's not uncommon for the baby to be on phototherapy and then come off and then back on. So during this time, we're going to be following the bilirubin levels and kind of seeing where how our levels are trending. Why do we treat hyperbilirubinemia? Well, we treat it because bilirubin is toxic to the brain. And if a baby has severe jaundice, there's a risk of the bilirubin passing into the brain. So prompt treatment is needed because significant lasting brain damage could occur if jaundice is not treated. So thank you all so much for sitting here and listening about jaundice in the newborns, and I'm hoping that you have learned a few new things. Here are the resources that you, of course, can access as well to learn more. And then one last thing before we go, we are going to kind of test your knowledge and see how well you took in the information. So I have prepared a little round of Jeopardy for today. So we are going to test your knowledge. So I need you all to divide into 2 teams of 4, and let's see how much you learned about hyperbilirubinemia in the newborn.